IVF Journal Club live stream. This is JC Darren, and welcome, of course, to this live stream featuring Dr. Ivf Journal, fertility specialist practicing in Adora Fertility, Brisbane. This afternoon, Dr. Ivf will tell us more about IVF transfer of fresh or frozen embryos in women without polycystic ovaries. This live stream is being broadcasted across LinkedIn, Facebook, Twitter, YouTube, and other social media platforms. And for those who are watching right now, you can also simply message us or send it via rostomov.com.au or simply by sending a direct message to our official Facebook page. To go through it accordingly, with us is our fertility specialist from Adora Fertility, Brisbane, Dr. Ivf Journal. Doc, good afternoon.
Good afternoon, Jesse. Thanks everyone joining this live stream. So sorry we had a bit of interruption in our live streams. Now we are resuming. So we will be continuing our IVF Journal Club. So so far we have been focusing on fresh versus frozen embryo transfer in IVF. So we covered two papers on this subject, Shi et al. And Chen et al. Now today we will be covering third paper on this question, which is published by Vuong et al. So this live stream has got two parts. One, as usual, we present the paper without any comments. The second, we will do critical appraisal of the paper. So this research paper, research study was conducted in Vietnam and in this large single center IVF clinic. This research was powered for 80% detection of 80%, which had the 80% of power, and which assumed the treatment, which is a frozen transfers, will increase live birth rate in absolute terms by 10%, from 30 to 40%, with alpha error of 0.05%, 0.05. So okay, so let us examine how they have conducted this study. So they included all patients who were undergoing first or second IVF cycle who did not have a diagnosis of PCOS. This was a non-PCOS patients undergoing first and second IVF treatment cycle. Then all patients had ovarian stimulation on antagonist regime using recombinant FSH ranging 150 to 300 units. So the dose of FSH was tailored according to age, AMH, and FSH. So once they had more than two leading follicles larger than 17 millimeters, they had an overdraw trigger and had egg pickup. So, and the randomization was conducted. It's very important. So point of randomization. So randomization was conducted on the third day of embryo development. So the embryos were checked on day 3. If they meet this following criteria, the patients were randomly allocated to control group, which is fresh transfer, or treatment group, which is frozen transfer. So the inclusion criteria for randomization was having more than one grade 1 embryo on day 3, and patient agreed to have 2 embryo transfers. So so it's very important to note that the randomization was done on day 3, which is cleavage stage of embryo. So the evidence may or may not apply to blastocyst stage of embryo transfer or freezing. So here we can see 391 patients were allocated to control group, which is fresh transfer, and 391 patients were allocated to frozen transfer, which is treatment group. So patients who were allocated to control group had an embryo transfer. The 2 embryos were transferred on day 3, and the remaining good quality embryos were frozen for future use. So in this group, we can see that out of 391 patients, 10 patients crossed over to frozen group, which means they were allocated to fresh embryo transfer, but they actually opted out from this option, and then they requested to have a frozen transfer. Hence, they did not have a fresh transfer, and their embryos were frozen. Now we look at the treatment group, and in treatment group also we had 391 patients allocated. Out of this, 9 patients crossed over to fresh cycle. So there's pretty much equal balance between patients crossed over to opposite group. The patients allocated on frozen cycle had their embryos checked on day 3, and grade 1 and 2 or more grade 1 to grade 2 embryos were frozen, and they didn't have embryo transfer. They had a freezing of all embryos on day 3. So, and the patients who were in the fresh group had embryo transfer and had a luteal support with cyclogist and had ultrasound scan at 7 weeks of gestation. That's a routine. So patients who had a frozen were allocated to frozen group, had a period and waited whole months, which is 6 weeks from the day of pretty much 6 weeks from day of randomization, and to start HRT frozen cycle. So during normal menstrual cycle, they had a HRT frozen cycle commenced, which used estradiol valurate 8 milligram daily, and luteal phase support was achieved using cyclogest 800 milligrams daily, which is very similar to the fresh group. And they had 2 embryos transferred on day 3 again. So embryos were thawed on day 3 and transferred on day 3. So neither group had a blastocyst transfer. Then both of them had all cleavage stage embryos. So pretty much the groups are well balanced, and there's very little crossover between the groups. And later we will see that they have done intention to treat analysis. So overall, so the conduct of the study was fairly robust. So now if you look at the results, they had, as we said, they did intention to treat analysis. So whether the patients cross over or not, all the groups randomized to a certain group were analyzed in that group. That is the best method of analysis in RCT. So if you look at the results, in the fresh group, 34.5% women had ongoing pregnancy. Actually, this study wasn't powered for live births. It was powered for ongoing pregnancy. The primary outcome here was ongoing pregnancy. Unlike the 2 previous RCTs we reviewed a couple of weeks ago, they studied live birth rate. So 34.5% patients had ongoing pregnancy in fresh group, and 36.3% women had ongoing pregnancy in frozen group. So the risk ratio was 1.05. And conclusion of this study was, among infertile women without the polycystic ovary syndrome who were undergoing IVF, the transfer of frozen embryos did not result in significantly higher rates of ongoing pregnancy or live births than the transfer of fresh embryos. Essentially, what they're saying is we didn't see any difference whether you did fresh transfer or frozen embryo transfer. Okay, so this is a conclusion of the study and on the conduct and methodology of the study. Okay, so now we can move on to a critical appraisal of this particular.
That's right. Thank you so much, Doc. So, in this upcoming series, of course, or series of slides, I'll be asking some questions, starting off with the validity. First up is, did the study address a clearly focused research question, considering, was the study designed to assess the outcomes of an intervention? Is the research question focused in terms of population studied, intervention given, comparator chosen, and outcomes measured?
Yes, answer to this question is yes, because all these 4 criteria was very well defined, and research question was really well defined and focused. Answer is yes.
Thank you, Doc. Now, next one is, was the assignment of participants to interventions randomized?
Yes, they were randomized. They had centralized randomization, which was very robust, fair method of randomization, where actually assessors or researchers were not involved. Yes.
All right. And finally, for the third question for the validity, were all the participants who entered the study accounted for at its conclusion?
Yes, all participants who entered the study account for its conclusion. It's yes. Then I will show the chart, which clearly demonstrates they accounted for each and individual participant. So, and also the participants were analyzed in intention to treat analysis, which is the best analysis, as we said. And so was the study stopped early? No, it wasn't stopped early. The study was completed as it was planned. So yes, this graph chart explains how many patients were screened and how many patients were eligible and how many patients underwent randomization. There were 782 patients who underwent randomization, and they're accounting for each and every participant. Okay, so
Thank you.
now, yeah,
Yes,
so
yes, Doc.
sorry, JC. So since we answered yes to all these questions, we can say that the study is valid. It
Mm,
does not necessarily mean the results are believable, robust, but actually study methodology is valid, and hence we can carry on to analyze this paper further. If answers was no to any of these questions,
mhm.
should we could have just stopped analysis now and bin the paper. Yes, we can continue now with the method section.
All right, for the method section right now, starting with the blinding, first up is were the participants blind to intervention they were given?
Yes, all participants, which is patients, were blind. Oh no, actually no, actually they were not blind to intervention
Mhm.
because they had to know whether they're having fresh transfer or frozen.
Thank you so much, Doc. Now, next up is were the investigators blind to the intervention they were giving to participants?
Answer is yes. So it is really hard to gauge this answer because let us say if they mean investigators by the people who's doing the research, it's possible maybe they can be blinded, but the people who are actually conducting the study in terms of procedures like embryologists and doctors and nurses, they cannot be blinded because they have to know what procedure doing for which patient. So the paper says they were blinded. Yes, I assume that was a scientist who is actually doing the investigation.
Thank you. Now, here is the next one were the people assessing and analyzing outcomes blinded?
Yes, so yeah, they can be blinded. There's like statisticians who's doing the stats. Yes, answer is yes.
Thank you so much, Doc. And next one would be were the study groups similar at the start of the randomized controlled trial, considering, of course, were the baseline characteristics of each study group, and also were there any differences between the study groups that could affect the outcomes?
Yes, so we can see from this table that the clinical characteristics and demographics of the patients at the baseline was very similar. For example, age was 32 on both arms, BMI, and all the causes of infertility, and so the number of eggs they got, number of M2 or mature eggs. So no, they were very comparable. Yes, answer is yes.
Thank you so much, Doc. Now, this time, of course, would like to ask this one. Apart from the experimental intervention, did each study group receive the same level of care, considering was there a clearly defined study protocol? If any additional interventions were given, were they similar between the study groups? And were the follow-up intervals the same for each study group?
Yes, sure. Certainly, they didn't have any additional interventions from the reported outcomes, so methods. So yes, here we can see that they were randomized at the time of day 3 check. From that point, only difference in the intervention was fresh transfer versus frozen transfer. Yes.
Thank you. Now, moving on with the results question, I'd like to ask this one. Were the effects of intervention reported comprehensively with, of course, the considerations below?
Yeah, so the biggest generally answer is yes, they have reported, but the biggest here pitfall in any RCT in fertility or IVF is power of the study. So this study was powered for clinical pregnancy rate, increase in clinical pregnancy, an absolute increase in clinical pregnancy from 30 to 40%. That's a massive jump. In IVF, we don't see any intervention which provides such a big increase in a live birth rate. So that is we will examine why it why unrealistic. It's just introduced massive type 2 error, which means there might have been some difference and we didn't detect. So, and also it was powered for 80%, just minimum power you want, and alpha error was 0.05. It's again minimum you want. So in that, using this power calculation, they said, okay, so we need just 712 patients total, 391 in each arm, and plus some patients who may not complete the study. So this is the minimum you can get in RCT in IVF. But again, that is severely underpowered study. I will explain why. Because properly powered study in two-arm RCT in IVF would be assuming only 5% increase in live birth rate, because as we said, usually any intervention IVF can increase. If it does, it can increase a live birth rate maybe 1 or 2% on absolute terms. So 5% is also quite a large jump. But even if we say they assume they would increase a live birth from 30 to 35%, and then they had a very good statistical significance level 0.01, which means 99%. They wanted to be 99% sure that the results they got is correct, and also had a 90% power. They would have needed 5,218 patients. So the difference is 712. That's bare minimum we can get. And actually, properly powered study in this research question would have maybe approximately 5,000 observations. From here, we can see that the study was severely underpowered. Yes. So answer generally yes, because they reported everything comprehensively.
All right, thank you, Doc. Now, next question here is, was the precision of the estimate of the intervention or treatment effect reported, considering where confidence intervals reported?
Yes, they did report confidence interval. They reported the precision of their findings. Yes.
Thank you so much, Doc. And finally, here's the last one. Do the benefits of the experimental intervention outweigh the harms and costs, considering all of these was, the size of the intervention or treatment effect, were harms or unintended effects reported for each study group? And finally, was a cost effectiveness analysis undertaken?
They didn't demonstrate any difference in the outcome. It might have been due to type 2 error again. There might have been actually a difference much lower than 10% in increase in absolute terms. But because it was underpowered, they didn't actually detect. So can't tell. Okay, so this is actually the overall chart. Here we assessed validity, methods, and results reporting of the study. So on the basis of what we have just examined, now we need to decide whether this paper is valid and can be used as a part of our clinical practice, or we should bin this paper because it is invalid and it can distort true evidence in effectiveness between fresh and frozen embryo transfer. So overall, we can decide that we will keep this paper in the library, but we should be aware that this research study is very underpowered. Thank you.
Thank you so much, Doc. And there you have it, ladies and gentlemen. Thank you. And that's IVF transfer of fresh or frozen embryos in women without polycystic ovaries with Dr. Ivf Journal. And to everyone, please go ahead and check out all our social media pages, our website, rostomov.com.au, and also adorefertility.com.au for more information. See you all again later today. I think we have another one live stream later on to talk about randomized controlled trials in IVF sample size calculation. Is that correct, Doc?
Yes, JC. Yeah. So after reviewing these papers, and we become more aware that actually sample size calculation is a big problem in RCTs. So, and we're going to have another 15 to 30-minute session, which will specifically look at the methods for sample size calculation in randomized controlled trials in IVF. Thank you. We'll see you in half an hour. Thank you.
Thank you so much, Doc. Thank you, everybody. See you again in a few.